presenting a really special edition today. We've got our European colleagues from all over Europe, and I'm really excited for this. We're going to dive deep into mesh products, more than you've ever wanted to learn about them, the implants themselves. From France, we've got the scientist, the man himself, Olivier Lefranc. What's up, Olivier? You guys can all unmute yourselves. Over in, I don't even know where you are, Barbara, but because you seem to roam around Europe a lot. But
I'm in Edinburgh
Barbara,
now.
Where are you now?
In Edinburgh, in Scotland.
Amazing. Amazing. Not too far from Dr. David Sanders. David, the man himself, gave a great lecture yesterday about implants, both intra-abdominal and extraperitoneal implants. How are you doing, David?
Howdy. I'm good.
Great to see you. And then we've also got Dr. Nicole Bouvy. How are you, Nicole? I'm glad you made it. It's great to see you. Nicole is in, you're in Rotterdam, right?
I'm in Maastricht in the Netherlands.
All right, wonderful.
Yeah.
And then just as interesting is Dr. Paul who's joining us from his hospital. That's the masked man on the right as a special guest. And soon we'll have in here a few other special guests to say hello. So we're here to talk about mesh. And where I want to start, I think sort of it would be fair to let Olivier get his first word in. But, you know, Olivier, you spent a lot of time yesterday talking about the difference between polyester and polypropylene. To be fair, I don't think a lot of surgeons really understand what they're implanting. I think if you interviewed a lot of surgeons and said, is your mesh polypropylene or polyester? And certainly the residents that are watching this, if you ask them if this is polyester or polypropylene, they won't know the difference just by reading the brand names. It's really something that doesn't trickle down to the clinical setting all too often. Can you teach us from a scientific standpoint, really, what is the difference between polypropylene and polyester, and why should we care?
Okay, so those are not the same family of polymer, basically. Without entering into too many details, those are two very widely used polymer in medical device industry, but also outside from the industry. Polyester is a family where you can find the PET that a lot of people know because it's part of our meshes, PLA, PGA, which are resorbable polymers, but also, for example, P4HB from Phasix, it's a polyester. So it's a family of polymer, and it makes it a little bit special because in the polymer backbone, you've got oxygen functions popping out from the main backbone of the polymer, and this provides a little bit of wettability to the surface. And it gives those specific part to the PET or to the PLA or to any polyesters. On the other hand, you've got the polypropylene, which is part of the polyolefin family, the same as polyethylene, which is widely used in orthopedy, for example. Those are the same families. They do not have any function popping out except a carbon function. So it puts them a little bit more hydrophobic, but still on the right range of the wettability threshold. So both are highly stable. I think the most important thing, and Dr. Sanders said yesterday that on an open pore mesh, the mesh represents a very slight portion of the whole surgical site, and both polymers are fine. The only thing that we have to remember is they are widely used, both, not only in medicine, not only in surgery. To give you an idea, they are used as bottles, soda bottles, both, and they are highly stable, because if they were not stable, we would not have those all ecological soda bottles recycling problem.
Wait a second, did you just say they're both used in soda bottles?
Yes, they are. They can.
So if a patient hears that, if a patient hears, look, we're using the same material used in soda bottles to fix your hernia, like, don't you think that they'll be afraid?
It's more to explain, is it stable? Yes, it is highly stable because it's the same kind of materials. You don't have a lot of polymers. Actually, they are nearly all the same, used in all applications. Credit cards,
I understand the science here, but Barbara, help me out. What about patients' perception of polyester and polypropylene? You have to unmute.
Hey,
Well, I don't actually think patients like quite realize the difference between polyester and polypropylene, but I think they call it all plastic, and they're really when you communicate with the patients, they're quite scared. If you say the word plastic, it means like they imagine, as you said, soda bottle or something like that, and they're very much against it. And then some polymers, like some that you mentioned that call themselves biological materials, sound a lot more sexy to the patients, although the science behind it might not be in their favor. So
it's a matter of the way you speak to patients, right? So, there's a massive drive at the moment to make sure that we recycle. Plastics are the enemy. I mean, you've got David Attenborough on TV showing you plastic floating in the oceans, microplastics. So if you use the word plastic, patient wants to run a mile. If you use the word synthetic prosthetic that allows your own tissue to grow into it, it's a very different conversation. And I think, as Olivia said, the mesh makes up such a small factor of the overall outcome for the patient. There are other parameters that are so much more important, probably most notably the surgeon, but then also the technique that's used, how the patient's pre-optimized, how the operations explained to the patient and what the expectations of outcomes are. All those factors are hugely important, but we want to try and maximize every percentage. So we want to try and use the best mesh. It's interesting, Olivier, you talked about polyethylene. So Usher was an entrepreneur in 1959 when he introduced mesh. He realized that there was a byproduct which was polyethylene from the oil industry, because he lived in a big oil producing town, and started to use that byproduct to produce the first mesh. So the first mesh, which was Marlex, was polyethylene based. And it was only years later that they changed that to polypropylene. And the reason they changed it to polypropylene is when they tried to sterilize the polyethylene, it melted. So that's where the polypropylene as a more stable polymer came in. But actually, these polymers have very little difference between them, I think.
It's
They are not the same.
They're not the same, but there's also this clinical concept. And Nico, you brought this up a little bit yesterday, that one of them may rupture more than the others.
No, not rupture, but the one causes more shrinkage than the other. And in the early days, polyester was mainly multifilament fiber and had an increased risk to cause infection. And nowadays you have monofilament polyester and monofilament polypropylene. And in my opinion, I think, Oliver, you agree, it's a bit better to use polyester instead of polypropylene because of the tissue reaction, the macrophages around, they show less activity if you use polyester compared to polypropylene. Do you agree, Oliver?
Huge debate.
How much do you guys think that the mesh material is important relative to actually the properties of the mesh? So for example, actually, if you said large pore polyester, or sometimes called lightweight, but what we really mean is large pore polyester and large pore polypropylene versus a small pore mesh, do you think it's much more important that actually we're using a large pore mesh and it doesn't matter whether it's polyester or polypropylene? Or do you think the actual material is one of the most important parameters?
No, one answer clearly is the positive is the most important part. Material can come a little bit after, but for all the properties equivalent, I'd rather choose something which is more bio-friendly. Let's say Dr. Bouvi spoke about the macrophages at the surface of the mesh, which have been shown to be less activated. But when we speak about shrinkage and all those kind of things, we do not have to consider only the material, but also the mesh structure. As the first multifilament meshes which were used were small pore and with a pore shape which may not have been adequate compared with what has been done today. So was it more on the structure? Was it more on the material? I do not believe that you have more shrinkage on PET compared with polypropylene. I clearly want to go where my biology wants to go. And if even in vitro, my cells prefer something, I would tend to go that way. But I would first choose the porosity, the structure of the mesh. You're right, Dr. Sanders is the most important part.
Yeah, I agree.
And then Nicole, can I ask you a question? And Barbara as well. So there was a paper published about 2 years ago with much better results in minimally invasive surgery with small pore mesh compared to large pore mesh. So it was against the trend. So actually there became this debate with actually for minimally invasive surgery, should you be using a small pore mesh? I mean, I've got my own theory of why that might be the way why they might have had better results with the small pore in that particular study. Can you explain that? Why do you think that came up?
I haven't read that study, so I can't really comment on this, but I would like to comment on something you said before, and it's the surgeon as a risk factor. And I said it to you before, and I wish I was as brave as you are, and I could say things as straight as you do. And if you think how many hernias are being performed every day worldwide, and how many surgeons actually know the very basics about mesh, it's quite it's actually really sad, I think. And it's very easy to for all these surgeons who don't really have like big hernia interest, it's very easy to say, well, it's the plastic mesh that caused all your problems. And I think that's where all the anti-plastic comes from, because and what IHC is a great medium in this, and it's connecting a lot of people and providing a lot of education to a lot of people who wouldn't have got it otherwise. But it's I think that's actually quite sad, and good on you for saying it loud, David.
Well, you say it's sad, but to be honest with you, we don't teach it, Barbara. And the reason we don't teach it is because a lot of the teachers don't know it.
So, Barbara, if I may react, I think you're totally right. It's really important that surgeons know what prosthesis they implant. And I think it's the tendency worldwide that more and more specialized hernia center pop up, in where the surgeons, they can know what prosthesis, what meshes they use. And that's important, because industry says, okay, this is really an easy to handle mesh. You can really tack it, or it's self-gluing, and it's easy to handle. And then a lot of surgeons think, okay, let's do it. Let's put this mesh in. But that's not the way to go. You really have to know what the reaction is of this mesh in the tissue. And what's a very good development, I think, is that more and more surgeons realize that just tacking a mesh intra-abdominally by laparoscopy is not the way to go. The tendency is really to place the mesh not in contact with the bowel, but in a more superficial level, and we should all try to do that more and more, and not place those meshes in direct contact to the bowels.
Philippe, you joined us. How are you? Do you agree? Can we put mesh inside the abdomen?
So I actually come from hospital, and I just did one two hours ago. So yes, in certain indications, I think there is still need for intraperitoneal meshes. In my own practice, this has reduced to about, I think, 5% of my ventral hernia repairs. So that's really the minority. It's my escape. So I really try to avoid intraperitoneal meshes. But okay, you sometimes need them in certain situations. So they have to be available, I think.
Let me ask you this. Have they let you down? in the cases you're using it in? Have you done IPOM plus hybrids and had to go back and say this was a huge mistake yourself, your own cases?
Yeah, sometimes indeed, because of adhesions, but not that frequent because I've done a lot. I've done, like I started 2002 after visiting Salvador Morales, so I've implanted, I don't know how many, but must be thousands of these intraperitoneal meshes, and the number of people that came back with major problems is not high. There is, like, if you follow them long enough, there's a substantial portion of the patients having recurrences. But that's probably with all techniques and depending very much on how good you follow them up and how long you follow them up. But indeed, and of course, there are some meshes. I think in the history learns us that because of competition and trying to get a market share, some companies put meshes on the market to be competitive without really found sound knowledge or sound scientific basis for that use. And all these meshes have gone now in the last recent years. We've seen meshes come and go, and there is a reason for it, and that is competition. We do have, I think we do have good meshes. So whenever we want to have a new mesh, it has to be evaluated if this is going to be better than the ones that we have.
So Philippe, which mesh did you implant 2 hours ago?
Well, I use we have mainly Medtronic meshes in our hospital, so it was a Symbotex mesh. But of course, that depends a little bit on the policy of the hospital. We have Medtronic meshes mainly in our hospital. That's the type of intraperitoneal mesh we have. Interestingly, this was a patient that in 2013 I did a physio mesh on inside a study that we had to abort the moment that the mesh was taken out of the market. It had some adhesions. It didn't look really bad actually, because now this hernia was actually at the umbilicus and the repair was higher up, and it didn't look that bad actually. There was some adhesions, but there was a new hernia at the umbilicus that was not really a recurrence. So now this patient has 2 intraperitoneal meshes.
Okay, so we can compare.
I don't know. There's no.
So can we go back to Nicole? Nicole, what do you use?
Well, I try to avoid, but like Philippe said, sometimes in 5% of the patients, I think that there's a need to do that, especially if the other layers are already obliterated with meshes. And then I think indeed a mesh with a coating of hyaluronic acid, like Cepra film or the Medtronic meshes, that they are okay. Physiomesh has taken from the market, and Proceed has been taken from the market. We did a lot of animal studies on those meshes, and what we saw in those studies is that we already could predict that this was really a mesh that gave a lot of reaction in these animal models. And of course, there's discussion if animal models can be compared with human data. But recently also we published a comparable study of the same tissue reaction that we saw in animal and human studies. So I think all meshes that come to the market should be tested in animal research. And I'm happy that Oliver Lefranc is doing that for Medtronic in Trevaux. And what some companies do is they think, okay, we have suture material from this substance. If we make a mesh out of it, then we can just put it on the market. And in Europe, you get CE mark for that. And you do not have to show what the mesh is actually doing in an animal model. So that's not the way to go. But I think as hernia surgeons, we have overcome the problem of recurrence. That is not a problem anymore. But the problem that we have to overcome is chronic pain, adhesions, perhaps a bit of shrinkage and infection.
Let me, I'll come back to you, David, in a second with the question. I'm going to say something. I've been using PCOX, which is not Symbotex. PCOX probably for about 15 years now, since it came on the market. It's you know, we all want to make these intra-abdominal meshes the same, but they're all different. And PCOX was Sofradim's mesh initially. It's a three-dimensional weave, and none of the others are truly three-dimensional weaves. They're all variations on two-dimensional weaves, including Symbotex, which is two-dimensional weaves put together. There's a little shearing force between the two if you look at the bare product. There is definitely a difference in the way these behave inside the abdomen. I'm sure of it, and I can't prove it. I don't know if they've done the same testing between the two meshes, and maybe Olivia, you can attest to that or not, but I know that Chalela did a big study on second looks, and he found that 87% of patients, when they went back on those second looks, 87% of them either had the little filmy adhesions or no adhesions at all. I call it the Chalela 87. No other mesh has got this volume of second looks, and I think that, like David said before, implantation technique matters a lot, the way and the patient and the technique. But I have not had the problems with my IPOM patients that everybody's saying, and so I continue to do it.
And Brian, how do you fixate this mesh?
I'm embarrassed to admit it, but I use Protax because that's what the hospital has on the shelf. We never, ever adapted to the absorbable fixation methods.
And do you combine it with transfacial?
Because my hospital never saw data. No transfascials. I close the defect. I deperitonealize the posterior fascia, and then I put the mesh in. Now, I do this technique for defects up to about 5 centimeters. I don't do this for the, let's just say the 4 centimeters to the 12s. Those are going to get the hybrids, you know, open lap or robotic, and then the big ones get TARS. That's a different ballgame altogether. So I'm talking about 1 centimeter to 4 centimeter defects. And probably the patient's body habitus matters too. I take that into consideration. I don't know if you do or don't. You know, the heavier BMIs, in my opinion, do better with IPOMs than really, really skinny people. That's just an observation. David, do you see that in the UK?
Which bit?
The BMI affecting what mesh?
It does. I mean, so there's a lot of IPOMs done in the UK, and it's a well-recognized technique. You know, I said yesterday in my talk, as a general rule of thumb, I don't believe that mesh belongs in the abdominal cavity, but you know, all rules are there to be broken, and there are certainly indications for intraperitoneal mesh placement. And I think you've hit the nail on the head. It's the obese patients who actually have a fairly small defect. They've got a good amount of intraperitoneal fat. And the reason you're doing the operation is not so much quality of life. It's actually to prevent the hernia coming through a small fascial defect and becoming irreducible or strangulating. So we use IPOM for that sort of niche group, but that's it. But in the UK as a whole, there's lots of people doing IPOM, and we spend a lot of time taking those meshes out. So because of problems, and I don't think that's because of the mesh. It's because of the technique. Yeah. And actually, it is not in principle for a laparoscopic surgeon. It's a simple operation, but actually there's a lot of nuance to it that's poorly taught, and it's very easy to slide the mesh so it's eccentrically placed over the defect. And not a lot of people are doing IPOM plus. So not a lot of people in the UK are closing the defect. No. So you've got an eccentrically placed patch that then ends up shuttlecocking into a hole. And if that's done in a thin patient, it's causing all sorts of problems.
Yeah, for sure. I saw Nicole's face. It's the same face I made. It's too bad.
Yeah, and Brian and David and Philippe, I was interested if there is an upper limit of BMI in which you say, okay, we only operate on you if the hernia is incarcerated. We do not do elective procedures until your BMI is below 30 or 35. What are your thoughts about that?
I'll let Philippe take it first.
For me, I try to get patients, if possible, to a BMI of 30, but if they have like a BMI of 40 and we can bring them down to 35, I'm happy with that. Then I would operate on them. So I will, but if they come 35, I still try to reduce them. But above 35, it's difficult. So one of the things that I've learned when trying to get, and some people do succeed because they start realizing how bad their health is, do succeed even without bariatric surgery to lose weight. And this is such a significant advantage for the compliance of the abdominal wall that it's probably much better than any Botox or preperitoneum that you could give. It's just the abdominal wall comes so much more compliant if you have to treat a large hernia. If they lose 5 BMI points, that's a big plus for your repair. Makes it much easier. And if they qualify, like in Belgium, it's a BMI of 40, you qualify for bariatric surgery, I will propose that to them. If they have diabetes and they have 35, I will propose that to them. That, of course, you can only do if they're mildly symptomatic, if they have too much pain or anything. But there's many patients that don't want bariatric surgery, although it's completely reimbursed in Belgium when you qualify for criteria. Still, many people don't want to hear about it. But okay, then sometimes they end up in the emergency department, and then you have to do something.
Dr. Pauli.
Yeah, hey, so I want to echo what Philip was just saying, and I mean I agree. I am, as an individual provider, the #1 referrer over to our weight loss program in our entire health system. So, you know, on a Friday, which is where I am right now in clinic, I send 2 or 3 people over per week to discuss getting a sleeve before a complex abdominal wall reconstructive procedure. And I follow NIH guidelines. So if your BMI is 35 and you have medical comorbidities, I will absolutely ask you to consider a weight loss surgery. Anybody above 40 automatically gets considered. And my cutoff is 40, primarily because that's what the NIH says is their cutoff. So if you're 40 or above, I'm going to offer a weight loss surgery. You know, I use that same cutoff, not specifically because of hernia related complications, because there's really kind of sparse data about where the complications and where the cutoff curve really, you know, actually makes a difference, but because for their overall health, it just makes sense, you know, to do it at that time frame. And as Philip said, you get that BMI down 5 points, suddenly a big hernia is just much easier to fix. And so we, you know, that's kind of our policy here, and we've published that, and we have pretty good success. It's very rare for people to be going through the program for a weight loss operation and actually wind up incarcerated. We only have had one patient who kind of failed the program in that regard. And he basically came back and he failed because he was vomiting chronically, but really trying to get through the program. And by the time he made it to our weight loss surgeons, he had vomited his way down to a BMI of 35. He met the surgeon, he reported all of his vomiting and his BMI of 35, and they kind of sent him over to the hospital, and we just fixed his hernia at that point. So it's safe and effective to do.
Yeah, I would say just be careful of the patient who comes to you with a hernia, who leaves with the new notion that they're overweight. Not everyone is, and not everyone's minds are ready to accept that as a patient. And they can get very upset with you as a physician when they don't see it coming. And so I think there's also a very delicate way to explain that to patients. I have seen patients get very upset with me when I explain to them that I think that their weight is prohibitive to a good hernia repair, and they've taken out the frustration on me.
I'm pretty charming in that regard, Brian. And while I definitely have had some people kind of get upset in general, it's usually not at me. And we usually have the ability to kind of talk with them about like the rationale behind it. And so like, I'm better at it now. I used to make people cry a couple times a week, and now it's like once a month somebody cries. My nurse practitioner, Bonnie, is back here chuckling because she's seen me do it. But we're pretty good. We got a pretty good dog and pony show about it now.
That's right. All right, so let's circle back to some mesh talk here as we get ready to fix the end. So when you say we bring mesh outside the abdomen, so the extraperitoneal space in the TAR, it's been told to me that there is a difference between the way polypropylene and polyester handle in TARs with large defects. I don't know if you're aware of these reports or not, but central mesh failure has been reported in case series with polyester in TARs where midline defects were closed. And now a lot of people are leaning towards using polypropylene, monofilament polypropylene, which is why Medtronic has a full array of materials that they offer. Do you agree or disagree with the concept that the monofilament polyester versus polypropylene matters in a TAR? We can all answer that if you can do it in like a minute.
No. We did a big post-market surveillance study, which included lots of TAR patients on Versatex, which is a polyester mesh. We had no recurrences. And all the central mesh failures were actually where a TAR had been done, but then the fascial defect hadn't been closed. So the back wall wasn't closed and it was used as a bridge. So I think in that instance, perhaps it's weaker.
David, does it matter if you put the lateral sutures in or not? A lot of people.
Yeah, I think so. I mean, but that's only anecdotal. And that's because I didn't like the lateral sutures. So we didn't do it for a couple of cases. And that's the one case we had, one of those cases, we had a problem. So we used the lateral sutures. Whether it actually makes a difference, or that's just anecdotal, non-evidence-based medicine, I'm not sure. But I don't think it makes a difference. But Versatex is now not recommended for TAR, so we don't use it. So we do use, we've switched over to polypropylene, but I don't.
Right, but it's not recommended because of these reports of central mesh failure,
because
which may or may not have been related to lateral sutures.
Yeah.
Anyone else have an opinion on that? No?
Yeah, I think if it's not in direct contact with the abdominal organs, then it doesn't matter so much.
Interesting. Okay, sounds good. Let's circle back to pore size real quick. I want to end with this amazing topic of pore size. Everyone goes by weight, but there's this push to stop talking about the weight of a mesh implant and the pore size. And Professor Lafranc, you mentioned that this optimal pore size should approach just less than a millimeter, right? So obviously we've learned that there's too big a pore size, but what is it about the millimeter pore size that surgeons, residents should start saying to themselves before they choose the mesh off the shelf? Hey, is this pore size, 0.7 millimeters? What is it? What's going on there? Why do we need to think about that as doctors?
You mean having a mesh, what is the limit where you should not take or you should take?
Very simply stated, no one that I know ever thinks about pore size before they implant it, in general. If you took, the 50 surgeons at my hospital, I would think about it, but I don't think anyone else would. They just want the product. They don't think about pore size. You're saying we should, and I'm asking you why and how do we teach these people that the optimal pore size is what you say, just less than a millimeter?
I think it's part to the also to the providers, like companies, to explain. For example, when we do a mesh, one of the acceptance criteria from the beginning is to have a pore size over at least 1 millimeter. That's one of our design inputs. We will always select that, and we can explain why. When a surgeon will use one of our meshes, he will be sure that it will be over this 1 millimeter pore size. So I think it's also part of the provider to explain, and it's part of education, I would say, to explain why this pore size matter and why it's so important. But it's really here for me that it can change the game, because we can imagine that nobody will take the time to look on all the boxes, what is the pore size of all the meshes that you have in the hospital. So it should be clearly stated by manufacturers, it should be, and it has been described by several publications that this pore size is the one that we need to have. So for me, it should not even be a question, actually. When a provider comes and provides a mesh, it should be one of the design inputs, which is go, no go, I would say. This is what we do. I cannot speak for other companies, of course, but I think this is what should be done from the beginning. So the question should not even be raised right now, unless under certain circumstances where maybe you can have some specific cases, but in most of the case.
Anyone else have an opinion about pore size?
I think
I think
there's
it's
a problem
really,
with.
sorry, Barbara, you go.
No, sir. I just wanted to say that there's a problem with the weight, that it's been so embedded into our heads for a long time. And when you think about it, the difference between heavyweight and lightweight mesh, what is it for a groin hernia? A gram, 2 grams? Is that going to make any difference? So I think it's just like something we need to start forgetting and reset our thinking process and think pores.
And there's something more. You can choose whatever pore size you want. If during, David Sanders spoke about that, if during the surgery, the mesh is flapped, or overstretched, then your initial pore size does not mean anything at the end, because you can have a pore like this or a pore like this, depending on the way you stretch the mesh. So it's really important for me to choose the right design from the beginning, but also, as Dr. Sanders said, the way it's implanted and the way the mesh is used is also a key parameter after that.
Real quickly, we have a quick cameo by Dr. David Chen at the bottom of our screen. David, thanks for joining last minute. We're talking about pore size and implants. You take out a lot of mesh. You think pore size is relevant?
Yeah, absolutely. I mean, I think that pore size has been our best surrogate lately. But the comment right before was so key, is that I think that if you look at, I mean, I've probably done, over 1,000 mesh removals. And when we look at what goes wrong, there are definitely people that have problems related to porosity and material and weight. I think that in general, a heavyweight mesh is heavy, and especially if you have a thin patient, they'll feel it more. So that foreign body sensation is relevant. But what you just heard is that if the mesh configuration is altered, then your mesh doesn't matter in terms of if it was lightweight or heavyweight or macroporous. And that's what we really see as the primary problem with meshoma, is that it tends to be the clamshell meshes, the folded meshes. In the groin, it tends to be, where you have a plug or PHS. And if it's not flat, it's not going to be macroporous and it's not going to be lightweight. And I think that that's such an important consideration.
Dr. Felix, Nijo's winner.
Yeah, thank you. Good day. Great Zoom. But as I just text you, is all this pore size and mesh going to ever make up for the surgeon? That's my question. I think it's the surgeon is the number one at the top of the list of whether it's going to work, fail, or not. And going back to Philippe's case of recurrence today, he talked about recurrence. The recurrence was not a recurrence because of the mesh. It was because at the initial operation, he didn't cover the entire incision, which is something we've always preached. So what comments do you guys make about that?
Well, Dr. Sanders, you can address that. Technique, how important?
We touched on this a little bit earlier, Ed. Hi. The mesh makes up such a small factor in terms of overall outcome. And by far the biggest prognostic factor is the surgeon and the technique. And then there's other factors that are hugely important as well, which is the patient, the way they're pre-optimized. I think the mesh is a small part relatively. However, if we're trying to line all our ducks up and get everything perfect, then perhaps we could argue that using the right mesh is one metric that we can use to try and make things better. With regard to large pore versus small pore, I'm a simple surgeon, so there's a lot of complicated science behind it. But the more material you have, so the smaller the pores, the more material there's going to be, the more of an inflammatory reaction the mesh is going to evoke. So you're going to tip the balance into what is a stronger scar plate, but a less compliant repair in terms of forming a more normal abdominal wall. So when you went back to your question, how do you persuade surgeons to use the correct pore size, I think it's that concept that needs to be reiterated.
That's reasonable. I'd like to give Barbara and Nicole the floor if they have any comments.
About
Yeah.
the pore size?
Yeah, or anything, or anything.
Okay. I think, I just can't agree more with David. And he keeps repeating it and saying it's about the surgeon. And maybe if there is 50 surgeons around you who refuse the concept of porosity and only insist on weight, maybe they just shouldn't be doing hernias. So they should learn that there has been another 10 years of science that happened since the weight concept was introduced. So, yeah.
Interesting. Certainly possible.
But I think that, Barbara, I think that I do agree that the surgeon has a tremendous ability to, to mitigate some of the problems and also to affect a lot of the outcomes. But I think that, if you look at the arc of history of hernia repair, we've done well because of our partnership, with having industry partners who make the products that we need, and so when you talk about when Irv Lichtenstein and Parvizamid started mesh-based repairs, they had polyester and polypropylene constructs and nylon constructs on the table, and they were trying to decide, what should we be using. But the reality is that Lichtenstein succeeded because, in general, even a moderately well done Lichtenstein works well in almost every patient. The same thing with even like a relatively not well done Lichtenstein still works well in the majority of patients. And the same thing applies for, in the modern construct of laparoscopic surgery. If you really mostly cover the myopectomy orifice, the vast majority of patients do really quite well. There's so many times I'll see a folded mesh, but the patient has no symptoms. We leave that alone. So mesh has helped us to do better with regards to recurrence. But when we really drill down to these quality of life metrics, that's where the patient is really best served by a surgeon who knows what they're doing. It's that by taking away, the folding, by choosing a macroporous mesh, by using a lighter weight construct, by knowing that if I did a really good repair, I can use a lightweight mesh, that gives patients better outcomes. So Brian, I wasn't on at the beginning, and I didn't want to miss, especially since we have the gurus of mesh, science here. Was there a answer to the question of do we have a better mesh material on the horizon? What does the future bring?
The Holy Grail. Nicole knows the answer. Nicole?
Yeah, I was looking for that, and then I was busy, so I didn't want to miss that.
No, I think Dr. Bouvier knows the answer of whether or not there's the optimal mesh on the market yet.
Well, together with the University of Aachen, we are working on an interesting mesh, which has elastic capacity, and it seems that this mesh is doing okay, but we are far from going to the ideal mesh. I think the best way to go is to have specialized closure surgeons who really take over surgery after Whipple or whatever surgery is done, and close the abdominal cavity in a 4:1 ratio, small bites, small steps, to use preventive meshes in people with weak collagen. And we have a very interesting finding how to detect if someone has weak collagen. So we have an electric nose, you can blow in it and it can shift between weak and strong collagen. And if you are a weak collagen person, perhaps we have to use preventive meshes and that kind of things. So I think the shift to prevention is more important than to repair, and we have to concentrate on that.
That makes a lot of sense. All right, we're going to wrap this up. Final thoughts by anyone who wants to offer them. And if not, I want to thank.
No, I was just to have a quick comment on what you said. For me, it's not really a question of material, but what is the need today. Most of the things that we know are based on old calculations, which were made quite a long time ago. And we are now in the era of the digitalization, and we can mimic. We can have a lot of things to better understand what is the real need behind that. And Nicole, you spoke about the collagen, but then how the body will react, how the abdominal wall will heal with a deficiency of collagen versus non-collagen. And I think those are all the tools which have to be implemented today to better develop and understand everything which is here. And science is here today to have a new approach and a new step about that.
That's right. I appreciate that. I want to thank Medtronic. I want to remind my viewers that Drs. Sanders and Bouvet and Lefranc gave great presentations. We'll post the link in this thread if they want to watch them today. On behalf of the International Hernia Collaboration and its members and its board, I want to thank Medtronic for trusting us to broadcast. For our European colleagues not familiar with it, this site is open 24/7. You may get tagged. People may ask you questions randomly. It's just you got to answer, and it's a closed group of just a small number of 10,000 hernia lovers. So I want to thank everyone for their time. Have an amazing weekend. Definitely do something memorable, and hug your family. Have a great day, and thanks again, Medtronic.
Thank you all.